Hello viewers of Dr. Tuteja talk show. It is pleasure to introduce a young faculty in endocrinology and pediatric endocrinology. It's a great. Today's guest speaker is a young dynamic Dr. Nikhil Lohiya from Nagpur. He is a pediatric endocrinologist and he will be updating us on precocious puberty, a crescendo of concern. He is DNB, FCPE, FCRPE, Fellowship Pediatric Indo, and he has worked and learned from Alder Children Hospital, UK, which is a teaching hospital in UK. It's a great achievement. Consultant Pediatric and Adolescent Endocrinologist at Silver Lining Pediatric Super Specialty, Center for Colors Children Hospital, New Era Mother and Child Hospital, Nagpur. Adjunct faculty, Pediatric Endocrinology, DMMC and Shanti Lal Hospital, Nagpur. Fellowship in Pediatric Endocrinology at Alder Children Hospital, Liverpool, United Kingdom. Trained 3 years in Pediatric Endocrinology, Bharati Vidyapeeth, SCJ MRI and Jahangir Hospital, Pune. Graduate from EPS School, PAT School and ESPE Summer School, Pediatric Endocrinology Schools. Reviewer Frontiers and Endocrinology, Indian Pediatrics, Journal of Pediatric Endocrinology and Metabology. Editor, CAP, News 2526, official newsletter of ISPAE. 48 publication in peer-reviewed index national and international journals. 75 research presentation at various national and international conferences. 14 chapters and manuscript in subject of pediatric endocrinology. 7 awards of various research conferences, including a gold medal CAC Award 2016. Areas of interest: growth, puberty, obesity, diabetes, metabolic bone disorder, DSD, and neonatal endocrinology. All these specialties, which is the coming future of medicine, and he is specialized. We are proud to have him today in Dr. Tuteja talk show. Our wishful aim is to update society on numerous issues. If you like, subscribe the channel. Your suggestion, comments are always welcome. I invite Dr. Nikhil to start the topic and he can share the slides. I request him to share the slide so that
Thank you very much, sir. I'm sharing my slides. My slides are visible, sir?
Yeah.
Yeah. Thank you, sir. Thank you very much, sir, for the kind introduction. Yeah, please take over.
My first question, your query is, can you define normal puberty? So
Well,
that the
very
people are aware of what is actually puberty.
Yeah. Very interesting question, actually, and very important. As we know, every child goes through the process of puberty from childhood. It passes to puberty and becomes an adult. Now, we have got 2 genders, male and female. What is the normal sequence of puberty? Let's understand that first. So what happens? A child grows. In a girl, first there is thelarchy, which is followed by pubarchy, and that is followed by menarche. So what is thelarchy? Thelarchy is nothing but onset of breast development. Pubarchy is appearance of sexual hair growth, and menarche is onset of menstrual cycle. It's very important that we remember this in 3 sequences. Because in 90 to 95% of the patients, thelarchy comes before pubarchy and menarche. In only about 5% or 10% of patients, pubarchy can come early, but menarche can never come before thelarchy and puberty. So the sequence is extremely crucial. This is how the sequence is. The timing we will discuss subsequently. Now the same when we discuss about boys. is gonadarchy, that means the increment in the testicular volume, 4 ml or plus. Pubarchy, that means hair growth in the pubic region and axillary region. And spermarchy, that means onset of sperm development. Again, 90 to 95% of the patients, gonadarchy, pubarchy, and spermarchy is the sequence followed. But 5-10% they can have pubarchy a little early. But it will never happen that spermarchy is happening before gonadarchy. That means there is something grossly wrong. So before we know what is normal, we should know the sequence, how it happens usually. Now coming to the most important point, which majority of our pediatrician colleagues, they ask, what is the timing of puberty? The normal timing of puberty is whenever you have a girl who's more than 8 years, if she gets a pubertal development, that's absolutely normal, right? About 8 years and plus, if there is a development of breast or pubic hair, that's absolutely normal. But if it is before that, it's absolutely worrisome. In boys, it's 9 to 9.5 years. Somewhere between that, if it comes, or after that, it's absolutely normal. But if it's coming early, that means it's late. It's abnormal. I'm talking about the delayed puberty, which is the other spectrum of it. When you don't have a breast development by 13 years, or there is more menarche by 15 years, that's considered as delayed puberty. And in boys, if there is no testicular enlargement by the age of 14 years, it is considered as late. Another way of describing it is, if between थिलार्की मतलब breast development से लेके menarche तक का duration अगर 4 साल से बड़ा हो, if it is more than 4 years, that's stalled puberty. That is also worrisome. And same is with boys, 4 years. Now you will say that this is what textbook is saying, right? Textbook definition, what I've said. What is the normal society, what is happening in India? So let's see first what is happening in India. This is one of our research paper we published about 4 years back, where we studied middle class girls and boys. I have specifically put only of girls table here. So what B2 means, breast development stage 2, Tanner stage 2. In a normal scenario, nowadays in a middle class family, it is happening by the age of 9 to 9.5 years. And earliest it can happen between around 7.5 years. And the menarche, which is here in the last column, if you see the last row, average age in a middle class family is around 12.5 years. So this is very important for us to understand what is normal. We discussed the sequence. Timings, we have discussed the timings, 8 years, 9.5 years boys, and 13 years breast development in girls, and 14 years gonadarchy in boys. It's very essential for us to know the duration also. 4 years, if it's more than 4 years, it's something to be worried of. And if it is shorter than 2 years, that means if breast development and menses, first period, menarche, the gap is less than 2 years or 2 years, it's rapidly progressing. I think I have answered the question, sir. Can we move on?
Next. We go to the next. How do you define the cutoff between the early normal puberty and the precocious puberty? And has it changed in last 5 years?
Yeah. So it's a very interesting question, actually, sir. Thank you for asking that question, actually. What has happened, if you see over a period of time, there is something called a secular trend in growth and puberty. What does it mean? With the time, the girls and the boys are getting their maturity early. Now, if you see in this slide, this is the data across the globe where all developed countries who have documented their research. In this left upper corner, if you see how the age of thelarchy and menarche has come down, but in the lower graph, you see now it is getting plateaued, flattening. So over a period of time, as the nutrition and the society evolved, thelarchy and menarche started coming early, and now it has reached to the nadir of over 11.5 years, even in the developed countries. But does that mean that precocious puberty is no more there? No. You look at the right graph upside, ENV is early normal variant, premature thelarchy is PT, PA is premature adrenarche, and ICPP is idiopathic central precocious puberty. Now you see the referral which has happened in the United States over the period of from 93 to 2007. All the referrals have gone up. Early normal variant have also gone up, but idiopathic central precocious puberty has also gone up. So firstly, it's a problem which is evolving. What is the definition? The definition still holds at 8 years. If there is a breast development in a girl by the age of, let's say, before the age of 8 years, it's not normal, it's early. Second, if there is menses by the age of 9.5 to 10 years, that's also early, that's not normal. Again, you correlate to the definition I said. 8 years if there is breast development, before 10 years there should not be menarche, because the gap should be minimum of 2 years and ideally 3 years or so. So if 8 years there is breast development, but menarche is happening at 9.5 years, that's early. So the definition for breast development is 8, for menarche is 9.5, and the tempo is 2 years. So yes, there have been of late a little bit variants, as we can see in the green bar. The variants are going up and up, but the definition of 8 years still holds the fort, with considering 3-4 points actually. Adult height being compromised, the social maturity, the psychological maturity of the girl, and handling of the practical prospects of menses. So I think 8 years is the answer, and tempo is another thing which we need to.
We go to next. What are the most reliable early physical markers that pediatricians often miss during routine child checkup, central versus peripheral?
Yes, very interesting questions. Now, this very commonly, why a pediatrician should know this answer? Because many times parents they say, हाँ, she is looking very tall, अच्छी लग रही है, लंबी लंबी लग रही है, मेरी बच्ची बहुत अच्छी है. So first and foremost, when the parents are not concerned about growth, they worry. Because usually, even if the child is normal, the parents have some or other concern about the growth. So the growth spurt, which is very visible to you without even examining the child, if you are serially monitoring the height of the child, if there is a sudden jump, then think that something is going not okay. The child perhaps is entering into puberty. If it is happening before the age of 8 years, abnormal again. After the 8 years of age, it's okay. The first and only clinical marker, which is non-invasive, even without seeing the patient, we can make out is growth spurt. Then there are a few other markers like mood swings, white discharge in girls, some form of some acne and oil skin. That is a little late marker though, and SMR changes. Sexual maturity changes. Now, we all should get into the habit of doing a clinical examination of the girl. Obviously, it has to be done with a chaperone. A lady attendant has to be there, and we should be comfortable because there is just some development of the breast at stage 2. Many times the complaint is it's tender. When you touch, it is painful. So even if you don't have any breast development, but that complaint of tender and touch gives you an idea that the girl is landing up into puberty, getting into the puberty. So that's another clinical complaint marker you can make out. Now talking about central and peripheral. Now we discussed the sequence right before, when there is thelarchy followed by pubarchy followed by menarche. If the sequence is intact and it is just happening early, that means it's central precocious puberty. I repeat, if the sequence is intact and if it is happening early, as the age cutoff we have discussed, it is central precocious puberty. Whereas if the sequence is garbad, that means the pubarchy is very rapidly coming up, thelarchy has not set in, that means there is something not wrong. This looks like a peripheral cause of puberty, like adrenal disorders. Or for the matter of fact, any of the DSGs can also present like that. Another thing is menarche before thelarchy. Again, it's a problematic thing because it can be because of ovarian cyst. It can be because of hypothyroidism long-standing, which we call as Van Wyk-Grumbach syndrome. So a normal puberty coming early is central. But if a deranged puberty coming anytime for the matter of fact or early, it is considered as peripheral precocious puberty. So I think it's very simple. Everything is clinical. There is no investigation we have discussed as of.
Next, there is a significant public concern regarding endocrine disrupting chemicals like phthalates, BPA, and parabens.
Yeah. So this is a very common problem which we discuss nowadays, that endocrine disrupting compound, plastics and everything. What is this plastic? Basically, it contains few compounds which are your phthalates and your BPA and then your parabens. Now, the basic about this is these are the chemicals which can mimic or block your hormones action. What is hormones action? Hormone means what? It's a chemical which goes from one place to another place. While going to another place, it has got a receptor on which it gets stick, and it signals that now you start working this way. This work can be mimicked by our endocrine disrupting compound. These are BPA, phthalates, pesticides, polishing agents, everywhere which we are living right now contains some or other form of endocrine disrupting compound. It's fine. I mean, you can't completely avoid it. Some amount of it is okay. Nature had made us like that. Now, what is the impact of this? The impact is it triggers the body to start puberty too early. This leads to accelerated growth, physical changes, and precocious puberty changes. And we need to understand that when IAP and other people are talking about environment, the environment includes this part. We should limit the use of these all compounds which can affect all of us. We need to identify the red flag signs. Are you using too much of plastic? Are you ordering too much of food? Food items which are preserved for a longer period of time. And we have to make sure that this is used less, because yes, they've got some or other definite role when it comes to precocious puberty, especially when it comes to the normal variant, which can progress into precocious puberty many times. So we should know that families needs to be counseled, be very close to nature as much as possible. And as far as endocrine disrupting compound, yes, they've got a role. They're available everywhere across in our current concrete jungle where we are living. So we need to just make sure that we minimize it, or we should avoid their exposure.
For the pediatrician, any specific question about lifestyle, diet, or environmental home habits that reliably tease out a potential EDC-related cause for early puberty?
Yes. Now we have discussed one thing. That's a very good question, sir, to be honest, because we have discussed what endocrine disrupting compound can do, why they are responsible for such problems. But how can a pediatrician or a clinician find whether the lifestyle or the way the child or the family is living is actually getting disturbed because of this? So what you need to know, you need to check the weight. High adipose tissue leads to increased leptin, and that triggers precocious activation. Basically, what is precocious puberty? Central precocious puberty, when I talk about, it's hypothalamus, which is connected to puberty, and puberty secretes the LHMS. So hypothalamus has got a pulse generator which gets activated at the right age. When the body signals that yes, the child is getting bigger, the girl can now conceive over a period of after 2 years, the trigger gets activated. And the trigger gets activated, all the hormonal cycle starts happening, and then you get into the puberty and gradually go into an adult. What is the reason why you need to go through the puberty? So you can reproduce, you can carry the baby. A female has to carry the baby. For that, they have to gain up to optimum weight. If the weight gain is early, rapid, fast, the pulse generator gets activated. Right. Now, another question is, frequent sugar spikes, insulin resistance, poor diet and high glycemic control again influences your hormonal disturbances. As I said, leptin, insulin is very much responsible for the same. They again goes to the hypothalamus and causes trigger. A sedentary lifestyle. I mean, if a patient is, if a child or the family is ordering a lot from Zomato, Swiggy, consume a lot of pizza, burger, preserved items, think that if there is a positive history, it could be linked to that. Limited physical activity, not going for play, it leads to poor BMR, potential metabolic issues get with, and it can affect hormone regulation. Again, the outcome is precocious puberty, early secondary sexual characters, acceleration of growth and growth. Now the question comes is what it should be done for that. You need to have practical recommendations. Stop having these kind of lifestyle issues. That means what? Eat homemade food, basic food, simple food. I think sir have already taken quite a few of podcast on the same. So number one, make sure that you follow good lifestyle, not putting a child subjected to obesity. It's very important for us. And sugary drinks and other things should be limited. So I think lifestyle changes are very important. Inquiring about lifestyle will help you to get an idea of EDC, and that itself to prevent this precocious puberty havoc which is happening currently in the society, it will be very useful.
So coming to next, that I think that very less pediatricians refer these endocrinal cases in time to the specific person. Should they not refer in time so that their growth and development could be monitored by the right person and the right in time for their growth and development?
Thank you very much, sir. So the question is very optimally phrased because see, the primary contact of a child is pediatrician. Anything happens, the mother and father, especially the mother comes, pediatrician, Doctor Saab, my child is having this issue. Doctor Saab, my child is having this issue. Can you address that concern? So for that, we should know that what it is and why it needs to be addressed. Now, what are the clinical tools which a pediatrician can do and he can actually address, and they should be referred. Before referring, make sure that you document an anthropometry. What is the height? What is the weight? Do an SMR examination thoroughly. Document it that you are able to see the breast. Breast seems to be stage middle, at least early, middle, and late. Even if a pediatrician picks up ki early breast development hai, middle hai, ya late hai, that is also enough for us in puberty. We don't need a detailed staging. We can't expect pediatrician to know everything, right? They have so much of work at their in their plate that we expect them to have some basic idea. That's enough. And if they can do, or if they have got a service, they should do a bone age. Now, thorough clinical history, asking about the lifestyle modification, when did the mother get menarche, how is it progressing, is it rapidly progressing, refer the patient. The reason I tell you, many times you do a lab, you get an LH of 0.3, 0.4, 0.5, 0.6. The lab reference value says the LH should be between 2 to 4. Now, that LH value is for adults. That's not for pediatrics. If we have a detectable LH of 0.2, 0.3, that means the pubertal onset has started. I'm not against you do, please do the tests. That's fine with me. But the interpretation is very critical. It's not about you got a magic wand. It's how you wave the wand. That's always been the question when it comes to endocrinology. And the interpretation of blood test has been extremely crucial because the norms are different. Like, एक 100 सेंटीमीटर का बच्चा है 5 साल का 4 years का and एक adult 100 सेंटीमीटर का. So an adult 100 centimeter is short, but a child of 5 years 100 centimeter is normal. Exactly that thing is ki LH of 0.2, 0.3 in a child whose SMR stage is stage 2 is matching to that. If it's happening early, that means it's precocious. That doesn't mean ki LH to kam hai. So that doesn't mean ki child is not in puberty. So be careful while we interpreting the test. Take help. I mean, many times you have got friends you can call and discuss, and that things can be done. Better to refer because anxiety and other things, and if something goes wrong, they come and sit on your head. कि डॉक्टर साहब हमने तो बोला था, आपने नहीं किया. So document a bone age, document anthropometry, thorough clinical examination, SMR assessment, physical examination. Many times you can get cafe au lait spots, which could be a marker of central precocious puberty. In peripheral precocious puberty, there could be darkening of skin, hyperpigmentation, and other things. A thorough clinical examination and documentation of anthropometry, SMR, and bone age will help us. I think that should be the thing bare minimum to be done before referring the patient.
As a pediatrician, can we treat? Should we treat? Do we treat?
Oh, that's a very good question, and that's a very common question. Even what happens, the patient comes to us, we tell ki this is how it is, this is how it has to be done. Then in my usual scenario, whenever I see a patient, I refer them back to pediatrician. That's why the pediatrician has to know this. If they don't know, then what happens? They'll call again, they'll get confused, and the patient will be confused. So the idea should be very clear. Now, it is based upon what thing? The decision is never made based on just because it's puberty or treatment. No. Firstly, it should match the clinical, biochemical, and radiological features should match. That means if the height is tall, the bone age is up, biochemistry is also showing precocious puberty, radiologically ultrasound is also giving us that the child is landing up early in puberty, that fits into the whatever precocious puberty you've got. It's never based on one thing. I repeat, it's never based on one thing. Precocious puberty, it's very simple given that you fit all the boxes. Like, then you counsel the parents and explain that this is the normal thing. This is how it happens. It is happening early, or it is a peripheral precocious puberty. So peripheral precocious puberty, there is no other goal. It's 95% it will be pathological. Unless proven otherwise, a peripheral precocious puberty needs to be treated. A peripheral precocious puberty, I repeat, needs to be treated unless proven otherwise. Central precocious puberty, yes, it depends on what stage the child is in. If it has come early, it looks to be very rapid advancing, the bone age is very advanced, then we give the option of treatment. Now, why do we treat? Okay, na? I mean, why should we treat? If puberty is just coming early, how is it going to make a difference to the child? Now, the reasons for that are number 3, number 4, and number 5. First and foremost is height compromise. Taller now is not always tall. Right. Many times when we see patients or our relatives, अरे इतना अच्छा लंबा बच्चा है, बहुत अच्छा है, और लंबा होगा पापा जैसा मम्मी जैसा. No, it's not always necessary. Look at the SMR stage. If the girl is in precocious puberty, because why I'm saying this point is girls, they come. She was very tall. अभी 2 साल पहले तो इतनी लंबी थी, अभी मेंसेस आ गया, अभी नहीं बढ़ रही है. तो the point I'm trying to make is there are a lot of myths and the beliefs. The system, the social structure is so that we go a lot by log कहेंगे क्या, लोग अच्छा कह रहे हैं मतलब अच्छा है. So I think that we need to break the myth. So height compromise can happen. Peer adjustment. Can you imagine an 8-year, 9-year, 10-year-old girl with menses getting adjusted with the friends? They will be playing all sorts of sports. They'll be going to socially meeting and going together. Birthday parties. This girl has to manage her menses, change the pads, gets depressed that why me? Why am I only getting this kind of thing? Why no other of my friends are having this kind of thing? Second is managing adulthood. Now tell me one thing. Can a brain of 10-year, 9-year, 8-year-old girl have a maturity of 17, 18-year-old? It's not possible.
No,
So you lose on childhood.
not at all.
You lose on your childhood, right? Don't you think that? I personally feel my childhood was very good. Everybody feels that. We all wants to go back and become a child. Don't want stress. Don't want any headache in life. And I'm not saying that that doesn't mean grow old. That means that let the child have his childhood. Don't deprive the child of his child. So many times they say, नहीं आजकल तो होता है बढ़ते हैं. हाँ, it's not true. Don't give them this kind of reassurance. It's not appropriate, right? We are not doing justice to the children. So I think that's important point. Now, when it comes to the treatment, how do we treat? It depends on the cause, obviously. If the peripheral cause is there, adrenal or any other cause, we treat the hormones accordingly. But when it comes to central precocious puberty, we give something called as GnRH analog. GnRH analog treatment, actually central precocious puberty treatment has evolved over a period of time. You can look into this. And in past, let's say 15, 20, 25 years, it is substantially good. The depot preparation of GnRH analog are available. What does it do? How does it work? GnRH in a normal person, in you, me, or anybody who's watching this, is secreting in a pulsatile fashion. That means what? GnRH goes to the pituitary cells and knocks. Secrete LH, secrete FSH. After that, it comes back. After some time, secrete LH, secrete FSH. So there is knocking constantly, and that's how stimulation, and that's how the pulsatile secretion happens. Now, the same hormone, the same GnRH, which is genetic engineeringly made with some tweak to make its work prolonged, we give from outside. It goes and it bangs the door of pituitary, stimulate the secretion, and after that it stops. Because it's not pulsatile, it's just one time back. So the receptors gets desensitized, and the moment that stimulus goes away, over a period of time, the natural pulsatile secretion starts. So it's nothing like we are doing something out of the way. It's something we are using the physiology and giving GnRH, which is a protein hormone. It's not a steroid hormone. It's a protein hormone. A little bit of tweaking is done in that to increase the half-life. Because earlier in 90s, 80s, they used to give GnRH daily twice, morning, evening, subcutaneous injection. तो उसको modify करके अभी एक depot preparation बना. So this we give, and yes, we should treat depending on the scenario. It has to be decided case to case basis. Obviously, we need to frame everything together. Look at the parents, look at the child, look at the compromise. What we are going to offer, it is going to affect the child. Then we should treat. Third, the treatment is very simple. It's available now. It's quite. The response is quite good actually, and they really do well, those kids. So I think I've answered the questions.
Yeah. What a pediatrician should know and tell parents regarding the treatment.
Very important. As we have discussed in the previous slide, a very important question for all of us. A pediatrician should tell, first of all, this is a protein hormone. This is not steroid. We are blocking steroids actually. We are blocking the production of testosterone and estrogen, which is steroid. Number two, the usage is temporary. It's the pause button which you are putting. You are not stopping the puberty. You are just holding it. Third, this will make your child gain height, give him more childhood. Most important, fertility prospects are not bad. It's not affected. Fertility is not affected by it by any means. Data across America, Europe, in past 20-25 years, it has been shown that whether you treat or not, it doesn't affect the fertility. Yes, there is increased chances of PCOD, but it's equal in both of them. Whether you treat or not, it's irrespective of that. Because they've got early puberty, that's because of that. The evidence is there, as I've discussed, across the globe. If you don't take the treatment, tell them very clearly, this is how it is going to be. The periods will come early. Managing periods will be difficult. Height will be compromised. These 3-4 points, if they know, that's enough. Because that's what they want to know. इससे क्या consequence होगा, करना है, नहीं करना है, क्यों करना है. Ultimately, it's the patient's or the parent's decision. But a pediatrician should know these 4-5 points, which are bare essential, because they'll come back to it. Treatment will help them psychologically and socially. It's not something we are giving without any evidence. Evidence is there. So I think that sums it up.
So what are the central versus peripheral issues, and what is the duration of treatment?
So when it comes to central and peripheral precocious puberty, the duration of treatment depends on the pathology. Let's discuss it out. If it's a peripheral cause of precocious puberty, definitely there is something going on with adrenal like CAH or something else. So you need to treat that pathology, and that pathology treatment perhaps need lifetime. Many times in boys, their tumor or something. You remove the tumor mass which is secreting HCG, AFP, the thing will be done. If that has got converted into central, which is very off the beat, but many times the peripheral cause can get converted into central because the body is adapted to it, so the body starts secreting. So for that, again, GnRH analog can be given. The treatment duration is, somewhere between 10.5 and 11 years of age, we stop the treatment for girls, and for boys, about 12 years. In special health children, like those who have got developmental delay or the maturity is not much in autism spectrum disorder, we can relax the definition a little bit. We can go about 1-2 years more. The treatment is very safely can be given up to 4 to 5 years. We usually don't recommend beyond 4 to 5 years. There is no watertight compartment that it has to be given by 11 years only. Some of the patients we do give, but stop at 10.5. Some of the patients we stop 11.5. Obviously, the financial prospects also need to be kept into mind. And the peripheral cause, as I've discussed, we treat the etiology, and the etiology could be tumor, the etiology could be something genetic. So if that is genetic, that will require treatment for a long period of time. And if it is just like tumor or something which is insidious, you just remove that, and that should be done.
So there are few questions like a girl of 5-year-old with menarche coming to you.
Yeah. So the answer to that is 9 to 9.5 years, never reassure them. First and foremost thing, never reassure them. Try to find where they are placed. Now, the most important thing is many times 9.5, 10 years they come, they say, doctor, she is able to handle the menses. Fine, she is able to handle the menses. The moment you say, now she has achieved her menarche, she will grow only about 5 to 6 centimeters. They get, नहीं डॉक्टर साहब ऐसा कैसे है, ये तो अभी इतनी लंबी, ऐसा कैसा बोल सकते हो आप? But that's the fact. That's the fact. Like today only I saw 2 patients. I said they came late to me, about 13.5, 14.5. They said, Doctor Saab, it's been 15 months, there has been menses. Another said it's been 3 years. One wants to join NDA. She said her height is 150 centimeters. They said it should be bare minimum 5 feet 2 inches. They said do something. I said, I'm sorry, I can't. No, Doctor Saab, kuch to hoga. I said, see, I'm here only to treat. Please don't mistake me. But the fact is there for you. I don't want to misguide you कि ये दवा ले लो, वो दवा ले लो. Another girl, they said, Doctor Saab, kuch to hoga. I said, no, it is not possible. It's 99% the bones are fused. So, do you really think that our children will do that? हमारे खुद के बच्चों के साथ हम ऐसा करेंगे? नहीं. We will definitely give them an option. See, ultimately, it's the patient's decision what they want to do. But they should not tell कि हमको बताया ही नहीं. So I think we should be very careful that these patients just refer them. I don't mean to say that we should treat all of them. It has to be decision based on everything taken into account. So never reassure. आजकल आते हैं, जल्दी है, normal है. That's not the answer, please. Just tell them upfront. This is how it is. Go and meet. Ask if you can do the bone age. It's well and enough. But remember, post menarche about 5 to 7 centimeters maximum. Ideally, 5 is the answer to that.
At 9.5 year, one should not only reassure, but should investigate and then proceed further.
Yes, definitely.
That's
just
what
to be sure.
I think you are suggesting.
Yeah.
Use of GnRH analog.
Yes, now use of GnRH analog we have discussed. It's a safe thing. The most common adverse effect which has been linked, I'm not saying it's proven, it is linked by few people with PCOD. But what we have observed, and if given for a period of, let's say, more than 4 years, the bone can be a little bit weak. That's why we don't give beyond 4 years. Second thing is PCOD, irrespective of treatment, the girls have got precocious puberty. They are prone for PCOD. Not all, but 20-30% of them, they are prone for it because the axis is not, the axis has got issues with that, and the obesity part and everything is going on. So it might be linked to obesity also, but there is an association. We don't know the cause, but definitely not GnRH analog, because whether you treat or not, the fertility prospects, the PCOD thing, all the things are very similar.
Can growth hormone be given together?
Now, this is, sir, you have asked me a very debatable point. See, it depends on two scenarios. First and foremost, is the height going to be within the normal range? By giving GnRH, is it going to be normal range? If that is the thing, that's fine. But if the height is going to get compromised, then you can give it. The success is not guaranteed. I repeat, the success of use of both is not guaranteed. About 60 to 70% they can have an increment of growth, but 20-30% they may not. So you have to decide based on the case. If the bone age is very advanced and you have to act really fast, you can give both of them. If the bone age is not that advanced and you have picked them early, like let's say 7.5 years only you have picked up and you have started the treatment of GnRH, then you don't need growth hormone. But they come after menarche, or they come very rapidly evolving by 8-9 years, 8.5 years, very rapidly getting into the puberty, then you can consider it case to case basis. The answer to that will be, it can be given, but it has to be decided case to case basis. Safe in safe hands.
What is the role of MRI?
Now, that's a very important question, sir. Thank you. Because what we see that all our adult colleagues, they do MRI for every child who's come for precocious puberty. Every child who has got precocious puberty, MRI kar lo. The answer to that is not. See, as I discussed, there's a pulse generator in hypothalamus. So it's not the pathology, any tumor or any hamartomas or anything like that is caused. So when you have a breast development before the age of 6 years in girls, MRI should be done. And if there is a menarche onset before the age of 8.5 years, MRI should be done. Why? The data in Pediatric Endocrine Society, which has been, I think it's been 20 years, it has been audit, which has been given, it's US society. They found out that after the age of 6 years, the neurological cause or any tumor or anything causing a precocious puberty is very rare. Those who are coming only with Thilaki. So it's not worth putting money in that and subjecting the child to MRI. And same is with menarche by 8.5 years. However, when it comes to boys with precocious puberty are always pathological, unless proven otherwise. That's why MRI for them is mandatory. I usually understand it this way. Girls, usually, we all have been in medical college, right? Yeah. So we had female colleagues and male colleagues. What a professor will give assignment, like your journal should be completed by this date. Girls will go 5 days before the deadline. Ki, sir, ho gaya, please sign for the boys. Sir, 2 din more. Sir, please 3 days more. So boys are lazy. Boys are designed lazy. So delayed puberty is more common in boys. And precocious puberty is commoner in girls. I don't know the analogy is correct or not, but I feel the nature has made women a little bit like that. That's why precocious puberty is more common in girls and delayed puberty is more common in boys. So I think that link can be understood by that way. That's why a girl with delayed puberty and a boy with precocious puberty are very big red flag for us.
Mhm. So this was a good answer of discordance of puberty is okay.
No, discordance is not okay. The sequence has to be followed. 5 to 10%, I said this second step can come early, but you never know whether it's pathological or physiological. So for that, we need to be very sure and we need to work up the child, basic hormonal profile, bone age, ultrasound, and then we can confirm. Many times, premature adrenarche, like adrenal gland starts secreting the androgens, and that's why the pubic hair growth comes early. Now, that could be a marker of mild CAH also. It could be a normal variant also. So we have to be absolutely sure that what we are dealing with. So the moment you see a discordance, that definitely needs a workup and evaluation.
So you are a tall by 8 year, you will be taller by 17 year.
थैंक यू फॉर दैट क्वेश्चन सर. इट्स लाइक आपने म्यूचुअल फंड का रिटर्न देख लिया, पिछले 5 साल में तो 20% दे रहा था, अगले 5 साल में पीस देगा ही देगा. देयर इज नो गारंटी फॉर दैट. It doesn't happen that way. Let's say if the boy is tall but the puberty is fine, then you can perhaps label it. Perhaps you can say that. That's not 100% true either. The ideal way of going ahead with this is doing a bone age, doing a thorough SMR examination. Too tall a child is also not good, sir, in anything in life. Too little, too small, not good, right? पैसा कम हो तो भी अच्छा नहीं है, खुशी कम हो तो भी अच्छा नहीं है, ज्यादा हो तो भी अच्छा नहीं है, right? The same is with height. Too little, too much, nothing is
ज्यादा होगा तो डायबिटीज होगी, एंडोक्राइन प्रॉब्लम.
yeah.
कम होगा तो malnutrition होगा.
True, sir. Very true. Very true.
So growth spurt happen after menarche.
No, big no. Big no. Wait, अभी बढ़ेगी. Puberty होने के बाद में, period आने के बाद में height बढ़ेगी. No, this is a very, very big myth among all of us. The growth spurt in girls happen between the SMR stage 2 and stage 3 time. Time to have growth spurt. That means first चले गया, second आ गया. Second से third के बीच में जब जा रहे हो तब आप menarche बोल रहे हो, मतलब stage 5 आ गई. So that's near 95% of growth is done by men. Second, in boys, when the testicular volume is around 12 ml, that times the growth spurt happens. So again, in boys also, it's in the middle of the puberty, the growth spurt happens. So again, this is a myth. Please don't put it across. That's what my request will be to all of our colleagues.
So a last little query. Equivocal cases with borderline by definition of puberty.
Yeah, see, equivocal cases, see, many times you get a telarchy or breast development. The patient is referred by the age of 80 or 3 months. Now, what is the onset of telarchy? It's not when you have seen. The onset has happened somewhere before that. You are seeing it at that time. So you need to inquire a little bit more. Go back. Mom, have you seen any changes like this before? She will say, हाँ sir, ये 6 महीने से. That means the onset has happened before the age of 8 years. So when I say equivocal, it could be either properly it has happened 8.5 years के बीच में, or it could be early. So don't dismiss them. All of them, they don't need treatment. All of the equivocal cases, we don't treat. We make sure that it is actual precocious. The height is going to get compromised, and then only we draft a treatment. It's not like कि हाँ चलो 8 साल के पहले आगे दे दो इसको जीना. नहीं. Many times it's a very slowly progressing puberty. The bone age is थोड़ा सा advanced. थोड़ा ही है. So perhaps the gap between telarchy and menarche is reserved. तो अगर 7.5 साल पे breast development हो रहा है, menarche 11 पे आने लग रही है, 11.5 पे लग रही है, then we don't intervene. We just say let's keep a watch. 6 months we take a review and then we take a decision whether to do anything. So equivocal cases are actually very difficult to deal with. It's not like it's the answer is now. Many times serial monitoring, serial assessment of the child gives you an idea. So I think fairly I can say that equivocal cases we have to be very careful. Many of them they don't need treatment. Many of them they need the best requiring treatment.
So Nikhil ji, you have made a very difficult topic a very easy and understandable. I think the pediatricians of country will be benefited and the viewers will try to understand their small queries which they often ask to the pediatrician or the general physician, and hope that they are benefited with your suggestions, your talk, and the time you have devoted for Dr. Tuteja talk show. We are really grateful. It was a very nice session, and I hope that will be very fruitful to the everybody. Thank you.
I must thank you, sir, in fact, to invite to make us speak on this topic, because we are, I mean, you have been very modest, take us here and discuss these complex topics, which perhaps nobody else is doing. So I must congratulate you that you are actually doing something which is helping the society and the pediatrician. And I must thank you that you have invited me and considering me. It's my honor actually to be talking to you. You always make things very comfortable whenever I talk.
I am very sure that all the young generation of pediatricians coming to this talk show, if anybody interested, they can write me, they can call me anytime, and they are most welcome. With the, but they should not come with the, they should come with the new thing, something which is not being discussed, not being talked about, not being thought of. That is
Yes, sir,
actually
true.
needed for the society.
Yeah, true.
We have gone, we are entering into the medical 3 now with the
Okay.
chronic diseases.
Yeah.
We have passed medical 1, medical 2, and now we are in medical 3, which has
Yeah.
not been cared of. And so the country with diabetes, cancer, hypertension, cardiac diseases, and the supreme of all these boss is obesity, which is creating problem. For
Yeah.
all these problems, the obesity is the main cause.
Yeah.
If we control our overnutrition, there will be no malnutrition in the country also, because everybody will be getting something to eat. So
Yeah.
people, some people are eating more, and some are more are not getting the food even.
True.
So
True.
that is not good for our country.
True.
Let us hope that the people try to understand and get something and
Yeah.
survive everybody.
Yeah.
Thank you so much, Nikhilji,
Thank you very much.
and hope to see you sometime other with the
Yes.
any new topic which you suggest us, and we will
Definitely.
like to invite you again. Thank you so much.
Kind of you, sir. Thank you very much. Thank you.